Welcome. We're so glad that you are taking an hour out of your day to join us today for this exciting conversation around health and homelessness. We have a great panel conversation prepared for you today. I'm John Masseri, the CEO of the People Concerned, and I want to thank our panelists for being here today. Just a couple of housekeeping items. We have several people registered to participate today, so if you have questions that you would like to submit for our panelists, you can do that through the Q&A button at the bottom of your screen. Please put the questions in the Q&A and not in the chat, because the moderator will be taking the questions out of the Q&A section. And also just a reminder that today's event is being recorded and will be available on our website later this week. So with that, it's my pleasure to introduce to you our moderator for today's panel, our Chief Program Officer here for services at the People Concerned, Tulin Smiley. Welcome, Tulin. You're on mute there. Okay.
Sorry.
You're off mute, and I'm going to go off the camera and let you take it from here.
Thank you, John. Welcome everyone to today's discussion on the intersection between health and homelessness. According to the National Healthcare for the Homeless Council, and not surprising to any of us here, people who are homeless have higher rates of illness and die on average 12 years sooner than the general US population. Homelessness creates new health problems and magnifies existing ones. Living on the street is extremely stressful and made worse by being exposed to communicable diseases such as TB, the flu, and of course now COVID-19, as well as violence, malnutrition, and harmful weather exposure. Chronic health conditions such as high blood pressure, diabetes, and asthma become worse because there's no safe place to store medications properly. Maintaining a healthy diet is difficult on the street, as access to fresh, nutritious meals is a daily struggle. Behavioral health issues such as depression, alcoholism, and other substance use disorders can develop and are exacerbated in such difficult conditions. Injuries that result from violence or accidents do not heal properly because bathing, keeping bandages clean, and getting proper rest and recuperation is often not possible on the street. Numerous health conditions among people who are homeless are frequently a mix of serious physical, mental health, substance use, and social problems. Poor health, high stress, unhealthy and dangerous environments, and an inability to control food intake often result in frequent visits to emergency rooms and hospitalizations. Healthcare services are more effective when a patient is stably housed, and in turn, maintaining housing is more likely if proper healthcare services are delivered. With this as a foundation for today's discussion, I'd like to introduce our panel. First, I'd like to welcome Shannon Fernando. Shannon is the Chief Innovations Officer at LA Christian Health Centers. She oversees special clinical programs, including street medicine, hepatitis C and HIV treatment programs, clinical satellite sites, all advocacy efforts for LACHC, and the clinic's overall COVID-19 response. Street medicine is a particular passion for Shannon, and she continues to engage in direct patient care, providing street medicine in Skid Row alongside her teams. Thank you, Shannon. Bo Hannemann is the Director of Special Programs for Anthem Blue Cross, California Medicaid. With over 18 years of experience in program development and implementation within various Medicaid-based programs, Bo has statewide responsibility for directing and overseeing the operations, business strategy, and alignment for special programs such as long-term services and supports, health homes, whole person care, palliative care, and social determinants of health. Katie Wren is the Community Health Manager at Cedars-Sinai. Katie's professional experience spans from social service to healthcare, including work in mental health facilities, community-based organizations, hospitals, and a private practice. Katie is currently managing the design and implementation of a systems-wide social determinants of health program, aiming to increase patient health by addressing health-related social needs in vulnerable patient populations. Welcome to all three of you, and thank you for being our panelists today. So I'm going to start the question with this question. Can each of you talk about how your line of work or your organization interfaces with people experiencing homelessness? What is the connection between homelessness and health? Shannon, can you start us off, followed by Bo and Katie?
Thanks so much, and good afternoon to everyone. Thank you to the people concerned for having me this afternoon. This topic, of course, is very dear to my heart. As was mentioned, I continue to see patients, direct patient care. So I'm the Chief Innovations Officer. As was mentioned, I'm a family nurse practitioner, particularly surrounding street medicine is my focus. And yeah, I think for me, the intersection is really important to discuss. And so I'm really excited to be here amongst the other panelists to discuss that further.
Bo?
All right, good afternoon, everyone. And thanks, John and Tulin for having me here today. So, just in terms of, quickly, Anthem Blue Cross and my role within the health insurance industry and that intersection between health and homelessness, it's really one that's been evolving, I think, quite a bit over the course of the last decade that I've been fortunate to be a part of. I think, looking back 10 years ago, which is around the time I started working for managed care health plans, there wasn't a lot of intersection between homeless services and the healthcare industry. And I think as a managed care plan, we didn't have at that point, didn't think that we had a lot of members who were experiencing homelessness. They were kind of carved out and left in the Medi-Cal fee-for-service world. But, over the course of the last several years with the implementation first of the Affordable Care Act and then kind of this national movement to start better connecting dots between all social determinants of health and the healthcare industry, things really started to change over the last several years and have led to a lot of program development throughout the state and throughout the country, particularly in LA County and the state of California, looking at things like the county's whole person care pilot and then the state mandated health homes program, which we've implemented, have really worked to target individuals who are enrolled in managed care and struggling with homelessness and housing, and really working to bridge that gap between services that are being provided with physical health, behavioral health, and then housing and other social supports as well. So, it's been a pretty big shift over the last several years, which has led us as a health plan to implement a lot of other programs that are focused on the homeless population, recuperative care pilots, housing navigation pilots. We've been providing some flex fund services in many of our counties throughout the state, and really working closely with more and more homeless service providers. And, I think coming up starting next year, I know we probably won't get into it much today, but would encourage everyone to pay close attention to what the state is doing with their CalAIM initiative, which stands for California Advancing and Integrating Medi-Cal, which really drastically changes the state's approach to providing Medi-Cal and gives health plans and health insurance companies more flexibility to engage in homeless services and actually pay directly for some of those services. So, it's really been interesting from a health plan perspective to see, over the last 10 years where, it was very, very little intersection to, this new environment where we're working towards where, there's a lot of overlap and we're really looking to take a more holistic approach to addressing the needs of our member and realizing the impact that housing and homeless services have on the overall health care of the member.
Hi, everybody. Thank you for having me here today, and thank you to my fellow panelists for being here. And so I'm from Cedars-Sinai, and although Cedars-Sinai is not your traditional safety net hospital, we still do see approximately 400 patients experiencing homelessness a month in our emergency department. And so in order to adequately and comprehensively care for this population over the past years, we have been creating new programs and initiatives in order to better meet the needs of this population. Personally, I come from a social work background. I've been on the front line with a specialty in our vulnerable patient populations, which for many years included working with our chronically homeless patients. And I also co-supervise our emergency department homeless navigators. And now through this new program, we're starting on managing our Community Connect program that with the target population of vulnerable patients, which includes but is not limited to our patients experiencing homelessness, working to how can we better identify their health-related social needs and connect these people to ongoing supportive services in the community and bridge that gap between healthcare. and the community. And so really, I feel very passionately that there is a very strong intersection between homelessness and health. Research shows that the biggest risk factors for poor health outcomes are non-clinical in nature. So things like social determinants of health, of housing, access to care, safety, food, actually account for 80% of your health outcomes, where medical clinical treatment only account for 20% of that. So with reduced life expectancy, as Tulin had mentioned, and these patients also have longer lengths of stay in the hospital, which is more exposure to other risk factors. It's just, I feel strongly that you have to address the basic human needs of life before healthcare can even begin to make a difference, and really feel that there really is no health without housing.
Thank you. Next, what are some of the common gaps in the system that exacerbate the homelessness and health crisis in LA from your perspectives? We'll start with Katie on this, and then Bo and Shannon.
So one big thing that we see, and especially as being a not-for-profit hospital, is a barrier that we encounter is this lack of coordination and collaboration between healthcare and homeless services, and especially for hospitals that are not county hospitals or DHS hospitals. It's really hard to bridge the gap between the healthcare and ongoing supportive services in the community. And so we're constantly having to think out of the box, or think of grant making or different types of programs we can develop in order to bridge that gap. And so really wishing that there was some stronger collaboration on a systems level. Other things like access to care, especially to behavioral health services and substance use services, that has been a really, really big pain point for us. And then, lack of preventative services by, people who are housing insecure, on the brink of losing housing. How can we better identify these people earlier and get them connected to services on the front end in order to hopefully prevent some of these more severe outcomes?
Thank you, Bo.
Yeah, I think from my perspective, kind of two themes come to mind. One of them, Katie kind of touched on, is really this lack of collaboration, and really, I think tied into that is the complexity of our system in LA County. I think we're very fortunate in LA County to have a lot of great organizations working towards homelessness, a lot of different funding streams being poured into it, and a lot of different programs. But that also makes it very difficult to navigate what everybody's doing and make sure that we're not working in silos, but working together, leveraging those resources and collaborating to make sure we have an efficient approach of serving more and more people. And I think that's, definitely a big challenge. I know, especially from a health plan perspective. I mentioned we've been doing several pilots ourselves to provide navigation and working with some community-based providers. We've engaged with, several of the hospital systems, and, found that, everybody's kind of doing their own thing and has an interest in collaborating and connecting the dots. But there's also so much going on. It's hard to carve out time to find a way to make that happen, right? And I think that, as we continue to get more and more involved, there's definitely a need to keep strengthening those levels of collaboration and keep pushing the needle forward, rather than focusing on, everybody kind of doing their own thing and operating in their own silo. So that would be one piece. I think the other thing, which is a gap, is really working with the homeless population to connect them better to primary care and behavioral health services in more of a preventative fashion, as Katie also kind of alluded to. Again, from our perspective, with the programs that we run, and even some of the state programs like the Health Homes program, those individuals who are members who are homeless tend to rise to the surface for us when they're already high utilizers of the healthcare system. They're spending a lot of time in an inpatient setting, or they're spending a lot of time in emergency rooms, and whatever conditions that they have become exasperated, right? And so that's the point that we're catching them most often at the health plan level, and to really have an impact on healthcare and addressing the needs of the homeless population. we have to find ways to do a better job of engaging those individuals, getting them to complete their annual wellness visits and meet with their primary care physician or their behavioral health specialist to make sure that they're taking care of those conditions before they exacerbate and get to this point where, they're really spending a lot of time in hospitals and driving up utilization costs.
Thank you, Shannon.
Yes, thanks so much, Katie and Bo. I think I totally agree with what you've shared. I think from my perspective, so I'll just share sort of from a medical provider standpoint, as well as still seeing patients on the ground. Just a little bit of background, LA Christian, we're an FQHC. We have a flagship clinic located in the heart of Skid Row in Los Angeles. And so that's sort of the level setting, so to speak, of where I'll be speaking from in terms of my experience. And I share that I think it's great that there are services available, and in particular healthcare and primary care as well as specialty care. But I think it's about access to that care, right? And how do we enable and create streams in which folks can access care in a way that feels safe to them, feels familiar to them, is trauma informed. As we all well know, people experiencing homelessness have been exposed or continue to be exposed to a lot of trauma. And so really, it's not only about having the services, but how the services are delivered, in what capacity. Do we go to them? Do we wait for them to come into our four walls? And I will say, I think the street medicine care is so key, especially during the pandemic. It's become even more important, where people have been afraid, to come inside a building, or models have been moved to telehealth, and a lot of people experiencing homelessness, our community members, don't have access to that readily. And so really having the care go to them, making it more and more accessible for our community members, our patients, our clients, our participants, whatever the term is that we use, depending on our angle. That's really key to, I think, ensure that truly it is the safety net for our patients.
Thank you. And so one follow-up, I think you touched upon, Shannon, is the access to care. How do we address the negative interactions some people are experiencing, who experience homelessness, have with medical professionals? For example, it may be challenging for someone to sit quietly in a hospital or clinic waiting room for their appointment. With that comes a stigma and a discrimination that some patients face from providers and other patients. So delays or reluctance to get treatment leads to adverse effects on mortality and morbidity, as well as higher emergency department utilization. And Katie, I think you had talked about this a little bit too. Do you want to step in?
Sure. So I have two thoughts on this. One is, I think really starting on a healthcare side to do a culture change, to start integrating roles like community health workers or homeless navigators, or these positions that are often people with lived experience but have an expertise of the community experience, what it's like, the community services. And so on the healthcare side, I think we need to integrate these roles as a part of our treatment team, have them be a part of the multidisciplinary treatment team, working with the physicians and the doctors and the nurses and the patients, in order to make sure that, keeping everybody in check, that we are providing the most culturally competent service to these vulnerable patient populations. These roles are also super supportive, not only in educating the healthcare members, but also supporting the patient through, these experiences, possibly sitting with them while they're in the waiting room, attending appointments with them, being their advocate, and helping them communicate with their healthcare providers, I think is really, really important. And that's something that at Cedars-Sinai we're working towards. And we've just started our first community health worker program, where we can have that position that is extending beyond the four walls of our healthcare institution, and bringing that expertise. And then secondly, and it is related, but it's education for our healthcare professionals. How do they provide more culturally competent treatment plans? How do they work with patients experiencing homelessness? Having our residents do, rotations through FQHCs like Saban Community Clinic, or, we're rolling out a social determinants of health curriculum to our physicians and residents that speak to. Like, if someone's experiencing homelessness and they have a medication that needs to be refrigerated, you need to figure out a different treatment plan because there's not a way to refrigerate that medication. So instead of labeling them non-compliant, getting frustrated and moving on, let's look at their experience in the community and give them an opportunity to be successful in their treatment plan by changing it to fit their needs. So hopefully, with education and also integrating roles like community health workers into the treatment teams could help a little bit.
Thank you. Shannon, I think you touched on that a little bit earlier too, so I'm not sure if you wanted to chime in here.
Yeah, I would say to really when we talk about building trust, right? I think one phrase that really comes to mind is consistency of presence, right? And so really having a consistent presence in the community and building rapport with our patients, with our community members, so they feel like we are invested in their care and we're not just there to kind of meet our own agendas, right? Oh, we want to make sure your diabetes are well controlled so that our quality measures are better, for example. But no, we want to make sure your diabetes is in control, for example, so that you can have a longer life, right? Your quality of life is improved. And so really being able to come alongside the patient, really healing and health, it's a journey, right? And so I think sometimes it's so hard, it's so easy to get discouraged when we have community members, especially those experiencing homelessness, that their journey may take longer than others, right? And we have to enable them to lead us, right? It's easy for us to sort of want to try to lead the station, lead the treatment plan, but ultimately, for it to be successful, they have to be at the center. We have to empower them to help walk alongside them, and really using methodologies like harm reduction to really be able to say, okay, what do you want to work on next? Let's negotiate that together. And ensuring that level of presence and that negotiation, so to speak, is really a consistent thing, so that they feel that they're truly safe and they can trust us.
Great, thank you. How can different healthcare entities, including insurance plans, hospitals, clinics, collaborate together to create systems change? Let's start, Bo, with you, and then go to Shannon and then Katie.
Sure. So I think three things come to mind for me. So one is, I mentioned earlier how it's difficult sometimes because there's so many things happening in the county, and it's hard to figure out how do you collaborate and leverage with all these different players when everybody's, to a certain extent operating in their own silos. But I think, the first thing is really just chipping away at it, kind of one small pilot at a time. Some of the things that we've been able to do, as an example, is throughout the state, we've done 4 of these now. We call them housing voucher pilots, where we've partnered with local housing authorities to get some housing vouchers that are dedicated for Anthem members. We've combed through to find our Anthem members who are homeless and high utilizers, and then partnered with other service providers in the community and provided funding for other wraparound services and supports. We did this in the city of Pomona, where we, worked with the city, with the housing authority, with Tri-City clinics, and with some local shelters, and really bringing all those players to the table to work together on this small pilot. I feel like broke down so many barriers in the way we communicate with these providers, and how we work together and leverage each other to better serve this population. And it was really a powerful thing. I think the first time we did it, it was, only for 17 of our members, but, I still remember, going out to one of the shelters in Pomona, where we had pulled all these people together and going through this list of potential individuals, and seeing everybody just quickly start bouncing ideas off of each other and figuring out how do you leverage all these different resources. It was an amazing experience. And I think we have to have more of that, because it takes that to start breaking down those barriers and enforcing and encouraging more collaboration longer term. So I think that's one thing. The second thing would be, really working more closely together on policy change. As much as we've been able to do, there are, it's an ongoing issue where, we can't do things the old way, and we need help from the state. We need help from the federal government to keep implementing policy changes to open doors for us to be able to work together. And I think that, homeless service providers at the community levels, and hospitals, and health insurance plans, and clinics, and everybody, need to be on the same page when we're working together for that policy change. You know, I can say that I've seen it happen sometimes where, you know, we almost feel like we're on different sides of the fence, right? Like the state, somebody proposes some policy and you know, on one side they're saying, well, the health plans don't understand this and they're going to screw it all up. And, you know, same way with the hospitals maybe. And then, you know, I heard people from the health plan side say, well, you know, these community-based people, they don't really understand how healthcare works and they don't understand what we need. And like, we've got to stop that, right? Like, we've got to get to a point where we're educating each other on both sides of the healthcare and homeless services systems, and working together to try to promote some positive policy change and doing that in coordination with each other, right? So we're not pulling in different directions. So I think that's to me, that's like a really critical one. And then the third one is, you know, just really looking at what's coming up with Colleen. You know, I mentioned this in the beginning, how we as a health plan will start to have more flexibility to pay for things like housing navigation, for security deposits, utility setup, for tenancy sustaining support services, you know, for recuperative care or medical respite, you know, different things like that. I mean, we're still, as a health plan, can't provide for rent. We can't pay for somebody's rent, but there are a lot of things that we're going to be able to do, which means that, you know, we're going to have the opportunity to have much more well-established working relationships with community-based organizations who are on the ground providing housing services to this population in our communities. And, you know, it's going to be a big shift. It's going to be a culture shift for us. I think it's going to be a culture shift for community-based organizations and clinics and others. And, you know, we're all going to have to be willing to bend a little bit. You know, I think from the community-based organization, it's going to take some commitment to thinking about, you know, what type of data is being collected and how do you bill for these services? Because I got to tell you, you know, working in a managed care health plan is completely different than working, you know, through grant funds or county funds or something else. And there's a lot more, unfortunately, sometimes there's a lot more red tape that we have to go through, which comes down from the Centers for Medicaid and Medicare Services and from the state. But that's part of it, you know, working within managed care. And, you know, so I think that's one example. And then another example on our side, how we have to think about things a little bit differently is really just this understanding of the population and what it takes to engage them. You know, I know Katie brought up in that last question the importance of community health workers. And, you know, we have a community health worker program, and many of our health home providers utilize community health workers as well. And, you know, it's a steep learning curve, you know, seeing how you engage somebody with a community health worker and really focus on building that long-term relationship with the individual is, you know, something that's powerful and has a lot of positive change, but it is not always quick, right? It's not a matter of, you know, I'm a community health worker and I go to a shelter and say, hey, I'm your community health worker and I'm going to pick you up and take you to your doctor's appointment, and we're going to build this big care plan for you and everything else, right? It doesn't work that way. Like, you have to invest time into building that rapport. And, you know, while we've done it to a certain extent, I still see on the healthcare side, you know, many individuals on the healthcare side, it's like, well, you know, we made a referral to you for this person who's homeless, and you said you were going to connect them to this program, but that was last week, and are they housed yet? Or, you know, have they been engaged? And you know, do we have a care plan together? And, you know, it's constantly, you know, going back and saying, well, that's not how it works with this population. And you don't get housing overnight. You know, this is something that's going to take a long time. And, you know, that kind of goes against kind of common practices that we do for other services we provide for our membership. And so, you know, it's a culture shift on both sides, but I think that, you know, if the payers are committed to it and the community-based organizations and clinics are committed to it, you know, this window is opening up for us to start working together a lot more closely and to bridge the gaps that we have today, and make sure that we're strengthening this intersection between healthcare and housing and homeless services.
Thanks, Bo. Shannon?
Yeah, thanks for this question. I think it's really important to talk about collaboration. You know, it truly takes a village, right, to really care for our homeless neighbors. I think And I think from my perspective, I'll just speak from like the clinic side, I think, and hospital collaboration. So for example, if we're seeing a patient experiencing homelessness on the streets, we end up sending them to the ER. They're usually discharged with some paperwork, kind of usually back to the streets. And the paperwork will usually get lost pretty quickly. And me as the PCP then have no idea usually what was done for them in the hospital, what the test results were, what went on. And the patient, sometimes they know, and sometimes they're not sure, right? And so I think it just highlights a really big sort of gap between what we see on the ground at the community clinic level and sort of what happens at the hospital side. And if there's a way to bridge that gap, right? And to information share, can we all use some sort of centralized system where we can communicate with one another when a patient accesses our different services? Is there a way for there to be a coordinator on the hospital side that can interact with our coordinator on the clinic side, right? Who could then work together to help really shepherd patients experiencing homelessness who enter the hospital setting, whether the ER or inpatient side, right? And so I think those kinds of just really on the ground type collaborations are really, really important, because at the end of the day, this is why a lot of our patients experiencing homelessness fall through the cracks, right? Because we don't know what happened to them. They could have had a CVA, for example, and we don't know about it. And then they come to us and we're not sure what medications they were started on or things like that. And so I think really that ability to communicate with one another, to ensure that our patients are taken care of, and even to avoid polypharmacy, right? Things like that, to ensure that our patients, again, remain healthy. Those are just some, I could have a long list, but I'll just highlight that one thing for now, but yeah.
Thanks, Shannon. Katie?
I really echo what both Bo and Shannon have said, especially in terms of communicating at time of discharge. I mean, it's a pain point. Oftentimes at the hospital, we're trying to find out who should we communicate with, but we don't know because we don't have access to clarity or all the different, health records. And so and then, I'm sure Shannon's street outreach team would call Cedars and ask, and we'd say HIPAA. So, I totally agree that that is a great opportunity for collaboration. I feel strongly there are a lot of different ways we collaborate, and a lot of it comes out service contracts, or we have a partnership with the people concerned to have a homeless navigator at Marina Del Rey Hospital. We have we have homeless navigators at the main medical center, and we have them plugged into all the different community collaborative meetings with coordinated entry systems and different things like that. So we have formal and informal partnerships, but really what I would like to see is, I think a lot of hospitals or FQHCs or programs have, all of these different pilots or individual collaborations. And while that works to serve Cedars-Sinai's patients or Anthem's patients, I echo what Bo was saying in terms of this more systemic collaboration that needs to happen, moving beyond our individual program collaborations to, fill these gaps or get our patients' needs met, and work towards more, group collaboratives. And, there are a few that go on in terms of, we have a regional social determinants of health convening that has 19 different organizations. Previously, we sat on the West Side Health Access Group that no longer meets, but that was a group of hospitals and insurance providers and community-based organizations and all these people in SPA 5 in order to figure out how we can collectively advocate for things to get and as Bo's talking, to extend beyond even to the state. And so I really think that there's a strong need for that type of collaboration.
Great, thank you. So a follow-up, I think you touched on this a little bit earlier, Katie, but a follow-up to question number 3 about how do we increase the experience or education of those hospital and clinical staff who are providing healthcare to special populations, but who may not have the specific training and skills to work with the complex needs associated with homelessness? Katie, do you want to start on that? And
sure. I wouldn't say I'm the expert on this, so I would, maybe Shannon could answer more eloquently than I can. But I would really say, in terms of this education, you have to partner with the experts. So being the healthcare provider and being, our scope limited to the encounter where we have that patient, whether it's primary care or the emergency department or inpatient, we're the experts on medical care. And or even our social workers are the experts on what do we have to do to get the immediate needs met, and of course always looking toward, we don't have the flexibility to be able to fully be thinking of the longest long term, because we have to take care of the immediate needs. And so I really think partnering with the experts in this field in order to bring that education in is really important. And so I did touch on, like, we're trying to do some of this internally in terms of creating a social determinants of health curriculum that our residents have to go through, where they have to think about, if I'm prescribing this treatment for diabetes in terms of diet and exercise and things like that, am I taking into consideration where this person lives? Do they live in a food desert? Do they have access to free access to nutritious foods? Are they on CalFresh? Like, all these different things. And so we are trying to do that internally. And then hiring our community health workers and people with lived experience to integrate into our team. On our responsibility to partner with the experts in this area to bring that education to us.
Thank you. Shannon?
Yeah, thanks so much, Katie. I agree. And I think partnership is key. I think from my perspective, I'll just share that, raising up the next generation of practitioners, right, and providers and people who have an understanding and a heart for people experiencing homelessness and feel, in a lot of ways called to that community is really important. And so one way to really raise up that generation is to host students, right? And we actually are really excited. We're hosting our first cohort of residents. So medical doctors who kind of want to go into street medicine, for example. And so we're really happy to see them, come and outreach with our teams. Huge shout out to the people concerned. Actually, we partner with TPC, and I love going out with the TPC teams, and our residents are out with the TPC teams, and they're really learning firsthand. What are the needs? What are the nuances of what it means to really care for someone experiencing homelessness, right? It's not just about prescribing medications, but it's about being present, right? And even just allowing them to share their story with us, right? And so, and all of that really has to happen kind of on the ground, kind of right there in the middle of sort of where the activity is, right? And so I think having students come through again in a way that we can make sure that it's done in an appropriate way, right? So that it's a commitment to a journey to learn, not just this one time, like, let me go and check things out and go on my way and check off that box, right? But kind of a commitment to a journey of learning, and approaching it from a spirit of humility, of saying, I'm here to really have the community members, my patients, teach me, I think is really, really key. And I always say my patients are my greatest teachers, and so I've learned so much from them in the last 14 years of doing this work. And so, yeah, so I would say raising up the next generation.
Thank you. Bo?
Well, I think the only thing that I would add is, because I think Shannon and Katie, your points are spot on. The only thing I would add is really, looking at what other resources and support can we provide to providers on the front line, meaning that, whether it's an easier way to assess members for needs around housing or other SDOH related needs. It's an easier way to connect to community resources. It's a way to make sure they understand that, as different groups are building out community health worker programs, really understanding what the role of that community health worker is and how they can help in addressing these needs long term. I think there's a lot of different things that can be explored. But to me, it seems like that's one of the biggest barriers, right? I mean, from my perspective, the membership we're serving is, they're Medi-Cal, and so as a Medi-Cal provider, the reimbursement rates aren't super high, and you've only got a limited amount of time that you can spend with an individual, and you're focused on the healthcare needs or the behavioral health needs, and to really take that extra time to drill into the social needs and then not just talk to them about it, but figure out what do you do with it when you find out they have this issue is honestly, it's a lot to ask for a frontline provider, right? And so I think the more we put in place to arm them with resources to say, hey, okay, there are all these other things that can help the person with these issues, you know, but you're kind of the front line, so we need you to engage on it and get the ball rolling. You know, I think that's really the key. And you know, we just launched a pilot, you know, looking at provider incentives, which is hopefully going to help a little bit to encourage providers to utilize some of the tools that we've developed to make it a little easier to assess for SDOH related needs, and then make that quick handoff to community-based resources. You know, it's still in its very early stages, and I hope it helps kind of ease some of that burden. But you know, the reality is you know, if you don't do something to ease that burden, you know, just providing training isn't enough, right? I think if you could provide 10 hours of training, and then at the end of the day, the frontline provider still doesn't have time to take all of this on themselves, you have to have those resources there to back it up as well.
Thank you. And the last question is going to be a fun one. If you could wave a magic wand, what other solutions or tools would you want in your toolbox? Bo, do you want to get us started on that? And then Katie, and then Shannon.
Sure. So I know we had a heads up on this question. I put some thought into it late last night, and we'll probably stick to the same answer I was going to provide before. You know, thinking, you know, it'd be great to just have enough housing for everybody, right? That would take a pretty powerful wand, but really, you know, when I think about it, I don't think that would solve the issue. Because if you look at what's happened in LA County and other counties throughout the state, and look at, you know, how many people have been housed through Housing for Health over the last couple of years, and other programs, and yet the homeless population continues to grow and grow, right? It's like for every one person that comes off the street, there's, you know, it seems like two more who are becoming homeless. And so, you know, there are really some systemic issues, I think, with our economy and you know, just with the you know, the gaps between the wealth divide between those who have and who don't have, which keeps growing and growing, you know, where if we don't fix those systemic issues, you know, just building enough housing to serve the population today, that magic wand would be a temporary fix, right? So I guess, you know, part of me says I wish we could just fix all those systemic issues within our economy so that, you know, we're not seeing more and more people struggle and you know, fall into homelessness. But I think, you know, in the meantime, if that wand could also help us better collaborate through data exchange. I mean, one key thing you know, for us to all collaborate together is to have shared information and easier access to data that we have on these individuals, to services that are being provided, and everything else. And you know, that's always a struggle. I know there's a couple of systems, you know, whether we're talking about coordinated entry or HMIS, so the county's lane system, you know, those have an opportunity to solve some of the issues, but you know, it's not, to me, it's not the dream system where everybody's just connected and looped in to be able to facilitate better coordination. But it can't just be a data system. There's obviously a lot of, when you're talking about housing and healthcare, with healthcare, you know, you also bring in HIPAA and protections, protection of an individual's personal health data, and you know, all these barriers where even if you have the system in place today, you couldn't always easily just share that data through that system. So I think, you know, that's something the wand would have to take care of as well, is opening up some better paths to encourage better data sharing.
Okay, Katie.
Can I say ditto? So I agree. You know, mine is very similar. I wish that we, in the magic world, we would all have the same exact system. Like we would just be using this, everything would be stored in one system and everybody would have access to it. Community-based organizations, hospitals, FQHCs, homeless service providers, where we could just, everybody could open it up and we could see this person's connected to this, this, and this, and here's their phone number, and the phone number actually works, and someone's going to answer and call you back. And I really think that would help keep people from falling through the gaps, because oftentimes we are pulling at straws. We are calling every 800 number possible. We're calling, you know, DMH, we're calling LASA, we're calling homeless, you know, E6 teams, all this stuff, just to say, can someone tell me, is this person connected to anything? They have to be, right? They've been on the street for 15 plus years. They have a chronic mental illness, like all these things. Someone has had to have encountered them. who is working with them that we can give information to. So if we all had access to that and shared it and could record it, I think that would be great. But then at the same time, just because you have that information doesn't mean that there is a service attached to that person. So then in my ideal world, it would also be that we had the capacity, like there was enough funding for these programs to have enough patients on the caseload to just be able to provide the services that are needed. And so that there was a place to refer that person into, or there was, that support for everybody. And so that would mean like, more mental health beds, more substance use beds, more housing, like just everything. It goes on and on and on. I feel like with this list, I could be like, this would be great, but then we need this. And then we also need this. So but I would start with being able to share information, all of us having the same interpretation of HIPAA, and then having a service available to attach that person to.
Thank you. Shannon?
Ditto also to what Bo and Katie shared, but I would say, and again, this list can be so long, but I would say the thing that comes to my mind is more permanent supportive housing. So, obviously housing is really important, and obviously that's the key to, a lot of what we do, but I also think the wraparound services needed alongside housing is really important. So whether that's outreach, care coordination, substance use services, mental health services, primary care, specialty care, all of that comes together. And so I think housing is so important, crucial, but then also in making sure that's permanent supportive housing where those services are included and accessible, and accessible in a way that is patient-centered and not necessarily the most efficient or convenient, but in a way that patients can readily access. So I would say that would be one thing I would love to see if I had a magic wand. Yeah, more of that.
Thank you. Well, I'm surprised none of you said that you would want a magic wand that gave more wishes, because our list seems to be endless on this. But that's all of our official questions, but we now have some questions that came in through our Q&A box, so I'm going to ask them, and we'll just take turns responding to them. How do we work to engage the unhoused community in preventative services, given that many individuals either are unaware of or go distrust the healthcare system?
I can speak a little bit to this. I would say, I think outreach is really important in a consistent way to get people linked to services and information. So letting people know where they can access care, where do they need to go, what are the hours, the locations, where are things moving. So I think outreach is really important. And I think, again, not necessarily expecting people to come to a central location all the time, but being able to go to where people are, so whether that's that's a park or, a food bank or, other places where people experiencing homelessness may already be accessing services, and then really couple, and bundle that care, so to speak. So we actually do rapid STD testing in one of the communities we serve, and it's this great partnership between public health and LA Christian and TPC and the outreach workers and health professionals coming together, and we go to places where people experiencing homelessness are already they already know, they're familiar with, they trust, and that's one way we can get kind of testing out into the field. Just an example. So I would say that outreach piece and going to where people are instead of expecting them to come to us is key.
Thank you, Shannon. This is for any panelist. How do you see your role in helping people experiencing homelessness with life skills, addressing mental health issues, hoarding, or general cleaning skills, etc.?
Well, I would just throw in one thing, because, I talked about Colleen and the opportunities that are available through there, and not to get too much into the weeds, but there are 14 what they're calling optional services in lieu of services that health plans can start paying for. And that's where like the housing navigation and the security deposits and everything falls in. There's also one of those, which is called dehabilitation, which is exactly what that is. It's working on those life skills and providing that mentoring to, everything from, how do you pay bills to how do you make sure you're keeping better track of your medications and your healthcare appointments and everything else. And, to a certain extent, I think that happens now with our community health workers, and probably Katie with yours that you're building out as well. It's part of that, building that relationship and then helping them, not just make an appointment to a PCP, the primary care provider, but also, taking care of these basic functions and helping connect to other programs and resources. So I think it ties in there, but I think there's going to be a lot more opportunity to cover some of those things through the healthcare system today. And I know in the meantime, as there are a lot of providers out there who that kind of mentoringship and that life skill coaching is kind of baked into the programs already. I think it's really just looking at the effectiveness of that and figuring out, how do we grow that to serve more and more people.
I agree. I mean, I think this is highlighting a need for, some type of like retention services. And I know that we do have, housing retention programs, but often there's more focus on just getting people housed and less of a focus on, now that they're housed, how do we keep them housed? And so I absolutely agree. Healthcare, our role is now becoming those that with our community health workers. Certainly we get a referral for help with transportation, or this person's not making their appointment, and that might be the initial referral, but we have to dive deeper into why are they not accessing transportation? Why are they missing their appointment? And sometimes it goes into, how do you keep a schedule? How do you know to cancel your appointment ahead of time and reschedule? How do you navigate, these medical systems, but also how do you have these life skills to grocery shop, budget, all of these different things. And so I think that definitely comes with our community health workers, but this speaks to, I think, a gap in terms of retention services.
Thank you. How can we start with our county hospitals, emergency departments, to help them not only recognize the shortfalls in care for chronically unsheltered people in the emergency room, but also how partnering with experienced local CPOs can help them achieve better outcomes? Anybody want to tackle that one?
It's a great question. I'm not sure I have an answer, except yes, we need to do it. I think really to ensure that the, emergency, for not just the emergency room, but actually even EMS, so even getting people to the emergency room, as well as folks who are actually calling for emergency care, so that providers, outreach staff, I think all of us, need to come together to learn what each other's roles are and how we can communicate and better work together. I think there's a multiple gaps there in sort of people experiencing homelessness accessing emergency room care, and sort of a stigma associated with that. Are you coming here for med, coming here just for a bed, that kind of stuff. And I think really having an understanding of what the experiences are for our patients experiencing homelessness, and having a dialogue around that. So whether that's at sort of the just the grassroots, like city level or county level, I think those dialogues and that level of collaboration, communication is really important. Kind of as I alluded to earlier with my example about sending folks to the hospital and even getting that aftercare summary back, right? So I think the dialogue is important, and learning sort of the different angle, because we're all serving the same population, right? We're really all on the same team at the end of the day, right? And so it's like, but we're just looking at it from different angles. And so coming together to say, okay, we're all on one team. How do we now navigate the different ways we're looking at things?
Thank you. This is also for anyone. At which level would collective collaboration between outreach programs and medical facilities be most effective? At the county level or the state level?
I would start with county. I certainly think at the state level would be great, but I mean, just starting at the county, because right now there's not that great of collaboration between, well, I can't speak for other, programs or county hospitals or state hospitals, but a lot of times when hospitals try and access outreach teams, that then becomes in reach, because you're not meeting the individual in the community in which they are. You're meeting them in this, space of how we have them in a medical system. And so there is little collaboration. And a lot of times it has to be, at least from our experience, it is this roundabout way of collaborating of like, well, they're going to go to recuperative care, and then they typically hang out in this area. And it would be way better if we're like, we have them and we won't discharge them until you connect with them, and then we can establish a plan together. And so I would love to start changing that first at the county level. And then of course, if we could do it at the state, I think that'd be great as well.
Yeah, I would just agree with that. I mean, from my perspective, you know, in my role, we cover Medi-Cal services in 29 counties, and you know, I oversee programs across the board. And as much as I would love to say, yeah, do it from the state level so it's consistent, and there's one approach which would make things much easier for me and my team, the reality is that doesn't work. I mean, every single county and even different communities within the counties all have very different infrastructures, different resources, different levels of need, and you know, different understandings of how they approach, you know, homelessness and better connecting members to home care, so or to health care. So you know, it very much does have to be, I think, driven at the local level. And then ideally, you know, what happens is from the state level, there's some collaboration and development of best practices and, you know, bouncing ideas off of each other and leading to some more consistency. But that can't start at the state level. Definitely not.
Thank you. We just have a couple of minutes left, so I'm going to ask this last question. Shannon, you mentioned permanent supportive housing and which wraparound services are needed. How can panelists provide integrated care to people once they have been housed to prevent them from falling out of housing? And I think that was to also your comment, Katie. Not sure who wants to answer it.
I mean, I can start, and then I'm sure, yeah, Katie or Bo can chime in. I'll just say briefly, I think the wraparound services that are needed should really be tailored to what the patient needs, right? There's not a one size fits all. That needs to be individualized. Every community member patient, you know, has different needs, has different ways they need to navigate, has different life skills they need to work on or improve or even develop. And so I think individual plans of care are really important. And so that will require the staffing, right? And the personnel, and whether it's a community outreach worker or a care coordinator, or an outreach worker, whatever the title really is, but really a partner, right? A partner to really walk alongside the patient to help even access the wraparound services and ensure they know where those services are, where to go or when to go. But I think in terms of the actual services, yeah, I mean, I think it's access to the healthcare, access to fresh foods and nutritious foods. I think it's access to, you know, whatever hygiene things they may need that they can't get within their own, you know, supportive housing scheme. You know, so I think there's a lot of different you know, items that are needed, but I think it's really a partner, right? Whatever we call that partner, we have a panel of people that partner really cares for. That's really important. I would say, yeah.
Thanks, Shannon. Katie?
I would really agree with that. It has to be tailored to each individual, but it would be great if we had, you know, these wraparound teams that had capacity to take on people. I mean, I've seen this firsthand, you know, a few years ago when I was on the front line working with people from our hospital. You know, I got somebody into permanent supportive housing. It took months, but I was so excited. And then when I came to do my first visit to see how it was going, a few days into it, he was, you know, sleeping on folded up cardboard on the ground in his house. He had the house, but he did not have a bed. He did not have, you know, and it's just, it blew my mind. And it was like, okay, we can get them a house, and then what? And so I think it is really important, and it is having these partnerships and engraved pathways to get these people connected to public benefits, to insurance, to medical homes, behavioral homes, but have somebody who is there every step of the way, and then even continuing to check in to make sure they have, you know, sustained all of those connections. And I think it's just the capacity issue of maybe there are teams that exist that do that, but you know, their caseloads are very heavy and there's wait list and it's hard.
Thank you. Well, I want to say that that's all the time that we have. I want to express my gratitude to those folks who submitted questions. And then I also want to thank you, Katie and Shannon and Bo, for speaking with us today. And thank you to all the folks who joined us to talk about the connection between health and homelessness. I hope this is only the beginning of our dialogue and that we will continue to discuss and collaborate with each other to bring better health outcomes to our homeless neighbors. Thank you, everyone, and enjoy the rest of your day.
Thank you.
Thank you.
Thanks.
Thank you.